early prostate cancer detection is clearly extremely important. Prostate cancer affects 20,000 Australian men each year and accounts for 3,000 men dying of prostate cancer every year. It's clearly a major health issue, and early detection with the potential of improved cure rates is something we should all aim for. What tools do we have at our disposal to detect early curable prostate cancer? We have PSA blood testing, digital rectal examination, and more recently some forms of imaging with multiparametric MRI. Most of the information we have is on PSA testing. There is an enormous controversy surrounding PSA testing for the early detection of prostate cancer. And so why would that be? Firstly, it's been shown and proven to decrease the chance of dying of prostate cancer. So why the controversy? Well, on the other side, it leads to over-detection and over-treatment of some patients where the cancer was never destined to cause any problem. So the aim of early detection, given the fact there's two types of prostate cancer, harmless ones and dangerous ones, is to be able to detect only the harmful ones. So why doesn't PSA do that? Because PSA in itself only gives one an impression of the overall health of the prostate. It tells one that something is wrong with the prostate. It might be enlarged, it might be inflamed, it might be cancerous, but it does not separate good from bad cancers. So what are the current recommendations in Australia for early detection of prostate cancer using PSA testing? Well, they recommend firstly a detailed informed consent, and secondly avoiding any of the confounding factors which might influence PSA levels. Informed consent means explaining that early detection of prostate cancer using PSA testing will decrease the chance of dying of prostate cancer, but may detect an insignificant, harmless cancer leading to overdiagnosis and overtreatment with the attendant side effects. These possible side effects include the anxiety of knowing you might have cancer, the side effects of biopsies such as infection and discomfort, and the side effects of treatment such as urinary incontinence and impotence. So should we throw PSA testing out? Well, my strong belief, and those throughout the world feel at the moment we shouldn't. We should improve it. So how can we improve it? Firstly, we can test the right people in the appropriate way. And secondly, we can improve the detection of significant cancers and avoid picking up harmless cancers with techniques such as MRI imaging. And finally, we can avoid treating those patients who have harmless cancers by a technique called active surveillance. So, should you have a PSA test? Well, generally, the biggest benefit are for patients between the age of 50 and 70. You don't need to be tested every year. Every second year appears to be sufficient. Testing very elderly men has no benefit whatsoever and will simply lead to stress and anxiety and no benefit to that man. In addition, testing very young men may create unnecessary anxiety unless, of course, they are at particular risk, that is, if they have a particularly bad family history of prostate cancer or they have a genetic abnormality which may predispose them to prostate cancer, such as the BRCA2 gene. In those patients with a very strong family history or with genetic predisposition, it's strongly recommended that testing from the age of 40, not 50, is required. So how commonly should a man be tested after informed consent and after understanding the pros and cons? Is it yearly? Is it second yearly? Is it 5 yearly? Well, it depends on the circumstances. Generally, every second year is sufficient. If you're at particular risk and your first PSA is already slightly elevated, then I think yearly is more appropriate. There is quite a lot of controversy surrounding digital rectal examinations in addition to PSA testing. For an experienced clinician, there is no question that digital rectal examination adds to the accuracy of early detection. What can affect the PSA testing? The following can. Firstly, recent ejaculation can raise PSA, so it's important to abstain from sexual activity for at least 48 hours. Secondly, sometimes the PSA, for no good reason, just goes up a little bit. It's always important to repeat it before being referred to a specialist. Thirdly, irritation in that area, such as long-distance bike riding or some recent infection, can increase the level. And finally, there are drugs used for hair loss, which can decrease the level of PSA and mask the level of PSA. All these need to be taken into consideration when doing PSA testing, trying to detect early prostate cancer. If your PSA level on routine testing in the appropriate situation is elevated, what next? The next thing to do is to have it repeated, and if it's still elevated, be referred to a clever urologist. What's a clever urologist? It's a urologist who is going to look at the big picture and give you a broad overview of whether it needs to be taken any further. What happens after your PSA test is found to be elevated and you've been referred to your urologist? The urologist will then take a full history, take an examination, and try and understand why your PSA level is up. Maybe it's just enlargement. Maybe you've had some infection. Or there may be a suspicion of cancer. If there is, some further investigations may be done, such as a multiparametric MRI, which will give further information about the likelihood of cancer. The next step might be a biopsy, and this may use the MRI for accurate targeting. So, should you have a PSA test? Well, as I've already said, it's important to have accurate informed consent. You need to know that there's good evidence that you will decrease your death rate by having a PSA test, but you will also increase your risk of overdetection and overtreatment. This has been addressed by modern advances in better PSA testing, in better imaging, in more widespread use of active surveillance, and by wiser clinicians. PSA testing is not for everybody. It's for those people who accept a small risk of having a overdetection and overtreatment, but who really want to minimize their chance of developing incurable prostate cancer. So in this highly controversial area, where do I think it's all heading? Well, I think it's heading to the following. I believe that future blood tests will be more accurate in predicting who's got a good and bad cancer. I believe that MRIs will more appropriately separate people who don't need to be worried from people who do need to be treated. I believe that the treatments will be less invasive, so the downside and the side effects of treatment will be less concerning for patients. And I also believe that genetic information will be able to tell us what type of cancer you've got, so you can more accurately predict whether it's a good one or a bad one, and indeed focus on the more accurate and tailored treatment. So if you're a man between 50 or 70, or a man with a strong family history over the age of 40, and you've understood the pros and cons, and you've decided to be tested, what can you expect? You can expect a blood test and probably a digital examination every couple of years. You can expect about a 1 in 10, maybe 1 in 15 chance of developing a prostate cancer. And the good news is, with appropriate MRIs and appropriate therapy, including active surveillance, you will minimize significantly your risk of dying of prostate cancer.